Hello. So, today we're going to discuss acute respiratory distress syndrome, also known as ARDS. So, this is a sudden progressive form of acute respiratory failure. So, the alveolar capillary membrane, it becomes damaged and more permeable to intravascular fluid. So with this, you would expect the alveoli to fill with fluid. So one way to assess the degree of impairment in gas exchange is to measure the PaO2 divided by the FiO2 ratio. And under normal circumstances, a PaO2, the normal level would be 85 to 100, and FiO2 on room air is 0.21, and that's known as the PF ratio, and that would be greater than 400. So if you have 95 divided by 0.21, that equals 452. So one way to assess the degree of impairment in gas exchange is to measure the PaO2 divided by the FiO2. So if you look at the picture, you'll notice the alveoli there. And so you have your pulmonary artery, okay, and the pulmonary capillary and the pulmonary vein. So in between the alveoli and the pulmonary capillary, that's the alveolar space that you see there. So with the stages of edema formation, you see there in letter A, the normal alveoli and pulmonary capillary. With the letter B, you see interstitial edema, and it occurs with increased flow of fluid to that interstitial space. And in C, the alveolar edema occurs when fluid crosses the blood-gas barrier. So not only is oxygen and carbon dioxide being transferred, but it's being that alveolus, it's being flooded with fluid. So with ARDS results. So with this, you would expect the patient to have severe tachypnea, hypoxia, decreased lung compliance, and diffuse pulmonary infiltrates. So with your etiology and pathophysiology, develops from a variety of direct and indirect lung injuries. So the most common one or cause is sepsis. Other reasons this can occur is due to CHF as well as pneumonia. So the exact cause for damage to the alveolar capillary membrane is not known. It could be pulmonary capillary hypoxemia because that gas exchange isn't occurring as it should. There also could be like a little microembolism, a clot. And also too, when you think about it, there's a loss of surfactant. So pathophysiologic changes of ARDS could be due to inflammatory or the immune system. Patients with multiple risk factors are 3 to 4 more times likely to develop ARDS. So what occurs, as you see on your PowerPoint there, the neutrophils are attracted and release of mediators. And that produces changes in the lung. And the pathophysiologic changes in ARDS, it's divided into three phases. One is injury, or the exudative phase. Two is the reparative, or the proliferative phase. And three is the fibrotic phase. And as you can see there on the slide, you would expect to see an increase in pulmonary capillary membrane permeability, destruction of that elastin and collagen, formation of microemboli, and of course you have pulmonary artery vasoconstriction. So with that first phase that we see, injury or exudative, 1 to 7 days after the initial lung injury, neutrophils adhere to pulmonary microcirculation, and you have damage to that vascular endothelium, as well as a continued increase of the capillary permeability. Also during this phase, you've got some engorgement going on. Fluid crosses into that alveolar space, and an intrapulmonary shunt develops as alveoli fill with fluid, and blood passing through cannot be oxygenated. So alveolar cells type 1 and 2 are damaged. If you recall, the function of surfactant is to maintain alveolar stability by decreasing alveolar surface tension and preventing alveolar collapse. So if you have a surfactant dysfunction, the airways collapse, then it leads to atelectasis. So alkalosis typically develops, and that's due to hyperventilation. And there's also the arterial O2 is decreased, or in some circumstances it may be normal. The hyaline membrane line of the alveoli, this contributes to the fibrosis and atelectasis. And of course, there's the decrease in gas exchange due to the compliance. So with the injury and exudative, you have the interstitial and alveolar edema and atelectasis. You've got that severe VQ mismatch and shunting of the capillary blood that results in hypoxemia. So the lungs become less compliant. So as the lungs become less compliant because of decreased surfactant, pulmonary edema, and atelectasis, the patient must generate higher airway pressure to inflate those stiff lungs. Higher airway pressure, it must be generated. This prevents alveolar overdistension and rupture by reducing the amount of pressure going into the stiff, non-compliant lungs. Further lung injury may be prevented. So as you can see there, you've got some, with this stage, increased work of breathing. Going to expect the patient to be using their accessory muscles in their neck, perhaps abdominal muscles to breathe. The respiratory rate is obviously going to be elevated. The tidal volume is going to be decreased, so producing respiratory alkalosis from an increase in CO2 removal. So you have decreased CO2 in tissue perfusion. So hyperventilation continues with a PaCO2 in the range of 25 to 30. And hypoxemia does not respond to oxygen therapy. So the reparative or the proliferative phase, this is 1 to 2 weeks after that initial lung injury. So obviously you would expect to see an influx of your neutrophils, monocytes, lymphocytes. All these are coming out. And you have a fibroblast proliferation. So you've got the inflammatory cells. And the lung becomes dense and fibrous as a result. So lung compliance continues to decrease. So you would expect the hypoxemia to worsen. Thickened alveolar membrane. You have diffusion limitation and shunning. In the reparative phase persist, obviously you're going to have widespread fibrosis. So if the phase stops, the lesion will resolve. And of course, at this point, mechanical ventilation becomes necessary. So again, if hypoxemia persists, you're going to continue on to the fibrotic or chronic late phase, which is 2 to 3 weeks after the initial injury. And the lung essentially is completely remodeled by collagen and the fibrous tissues. So again, you would expect to see that decrease in lung compliance, decrease area of gas exchange, pulmonary hypertension, and that results from the pulmonary vascular distension or destruction and fibrosis. So severe respiratory failure occurs. You have progressive hypoxemia. You would also expect to see an increase in your lactic acidosis, CO2 retention, and an increase in those hydrogen ions. So some persons survive acute phase while the pulmonary edema resolves and make a complete recovery. Others, like I mentioned before, they require mechanical ventilation. So some of the early signs that you would expect to see with this is your tachypnea, cough, restlessness as well. Physical exam, you might hear scattered crackles, especially in those bases. So with your ABGs, mild hypoxemia, and respiratory alkalosis. So with this, you would expect to see a high pH as well as a low CO2, and that's caused by hyperventilation. So if you did a chest x-ray, clearly you would expect to see interstitial infiltrates because the interstitial space is filled with the fluid. Late clinical manifestations, respiratory distress becomes more evident as the work of breathing increases. Tachypnea, intercostal, suprasternal retractions, those may be present. With your pulmonary function test, they would reveal decreased lung volumes. So when you have decreased compliance in lung volumes, so this person obviously can't get that oxygen. And with decreased lung volumes, you expect to see restriction versus obstruction. Also a decrease in functional residual capacity. And so FRC, that's the amount of air remaining in the lungs at the end of normal expiration. So with the late, again, you're going to see bilateral, interstitial, and alveolar infiltrates on the chest x-ray. Mental status will worsen. Patient will look more pale. The crackles will be more throughout the lungs. Hypoxemia despite increasing the patient's FI2 by mask, cannula, or endotracheal tube. And that's a hallmark of ARDS. No matter, you can continue to increase that oxygen, but the hypoxemia is not going to get any better. So ABGs, they may initially demonstrate a normal or decreased PaCO2 despite the severe dyspnea and hypoxemia. Hypercapnia, that signifies that respiratory muscle fatigue and hypoventilation are occurring, thus interfering with optimum gas exchange. So as ARDS progresses, profound respiratory distress requires the patient to have an endotracheal intubation and positive pressure ventilation. You may recall the term PEEP, that keeps the alveoli open. So a pulmonary artery catheter typically needs to be inserted to determine the state of fluid balance as well. The chest x-ray, you may see a whiteout or a white consolidation and widespread infiltrates throughout the lungs because that fluid is just increasing. So if you turn and you look at the x-ray, you can see some of the infiltrates on here. So some complications that we're going to discuss, and we've discussed this before: ventilator-associated pneumonia. You want to try to get your patients off the ventilator as soon as possible. If you are working in the ICU, be sure that your respiratory therapist is getting a sputum culture since the patient is on the ventilator. That will help identify the organism, and it will tell you if the patient's on the wrong or the right antibiotic. Barotrauma, volutrauma, high risk for stress ulcers, also the patients at risk for renal failure, liver, as well as heart failure. So a little review on ventilator-associated pneumonia. If a patient's on the vent for greater than or equal to 5 days, this typically does occur. VAP, it occurs in as many as 68% of patients with ARDS. Aspiration and GI contents, especially in patients receiving enteral feedings. So some strategies from preventing this. Strict infection control. Obviously, you would expect that head of bed to be elevated 30 to 45 degrees. Sedation holidays. Sedation makes it worse, right? Also, the patient is at risk for a blood clot, so you need some prophylaxis against that, perhaps some Lovenox. And of course, you want to make sure that you're doing daily mouth care with these patients. Barotrauma, that results in the alveolar air escaping from a ruptured alveoli. So rupture of overdistended alveoli during mechanical ventilation. And this can lead to pulmonary interstitial edema, emphysema. It could cause a pneumothorax. You may feel sub-Q emphysema as well. You have what is known as acute respiratory distress syndrome clinical network. Typically, it advises that the patient be ventilated with smaller tidal volumes and a higher PaCO2. You want the CO2 to be a little bit more increased. With volutrauma, This is when you have damage or tears in the alveoli. So this can occur again with large tidal volumes, um, especially ventilated with non-compliant lungs. So you have these little fractures and movements of fluids and proteins into the alveolar spaces. So again, you need smaller tidal volumes. With stress ulcers, this is bleeding from stress ulcers occurs in about 30% of patients. So ways to management strategies. So obviously correction of the predisposing conditions, prophylactic anti-ulcer drugs such as your proton pump inhibitors, protonics, mucosa protecting drugs such as your sucralfate or carafate, early initiation of enteral nutrition. Other things you would expect to see with the heart, arrhythmias, the brain, the patient may have increased confusion with the kidney, bicarb retention with renal failure. Also the muscles increase lactate that does produce to hypoxia. So with the renal failure, you have ultimately decreased renal perfusion. So it could be due from hypotension, hypoxia, or hypercapnia. Also, as well as some nephrotoxic drugs. Keep that in mind, especially with your antibiotics, your bank, especially, is nephrotoxic. I'm going to skip over a few slides here. And of course, remember with your elderly immunizations, the Prevnar 13, that should be given at age 65. The following year, they'll get the PPSV 23, and that's at 66. And of course, daily or yearly influenza vaccinations and the shingles vaccine at 65 years of age. And I'm going to skip through to the nursing assessment. I feel like we've addressed most of that, and I'm not going to read through the nursing diagnoses. Recovery, so a PaO2 of greater than or equal to 66 millimeters of mercury, and adequate lung ventilation to maintain a normal pH. Obviously, you want to hear clear lung sounds. You would expect to administer oxygen, typically a high flow system. You're going to continue to monitor the patient's oxygen level, frequent ABGs. With respiratory therapy, I did mention PEEP. Usually it's at 5 centimeters of water, and it compensates for loss of glottic function. And that can be caused from the ET tube. PEEP, it keeps those alveoli open, and it increases the FRC. Usually PEEP 3 to 5. Higher levels of PEEP may be used in patients with ARDS, about up to 10 to 20 centimeters of water. As for positive pressure ventilation, this can compromise venous return to the right side of the heart. So obviously you're going to see a decrease in your preload, cardiac output, blood pressure. Higher levels of PEEP can hyperinflate the alveoli, so reduction in blood return to the left side of the heart and a dramatic reduction in blood pressure. In addition, high levels of PEEP or excessive inspiratory pressures. So then that can result in your baro and volute trauma. So positioning strategies, turn the patient from supine to prone position. You may have seen this in the ICU. So when the patient is in the supine position, mediastinal and heart contents place more pressure on the lungs as opposed to when they're in the prone position. And that predisposes the patient to atelectasis. There's also a bed. Now, I can't say I've ever seen this type of bed. It's got to be pretty expensive. And you've got a photo of it, the roto prone bed. Other positioning strategies, continuous lateral rotation. That's slow side to side, less than 40 degrees, 18 to every 24 hours, as well as kinetic therapy. That's rotated side to side, greater than 40 degrees. Medical supportive therapy, maintenance of cardiac output, tissue perfusion. Obviously, the patients have hemodynamic monitoring. You want to monitor cardiac output and blood pressure, administer any crystalloid fluids or colloid solutions, or lower the PEEP. Obviously, the patient needs some enteral or parenteral feedings. Other things you're going to do, INOs, daily weights. So I think that's it for this chapter. Try to keep it relatively short. Make sure you look over your audience response questions.